Thank you very much for the privilege to be able to talk to you all. And it's great that this meeting will be recorded. If there are others that won't be able to look at it live, they can stream it later. Uh, there is a big caveat to this as well. This is hard stuff. I don't think you're going to find this easy. I hope you'll find it interesting. I have tried to make all of the concepts as easy to get your head around as possible. You will definitely see that I am. This is the same as myself in clinic. I love a good analogy. So everything's always with a story or an analogy to try and understand these concepts better. But what I always say to my patients, some of them really surprise me. And, after 6 months, 9 months, they do become pretty expert in things that I think most highly qualified nurses, highly qualified doctors mightn't get. And the reason why they become experts is really quite depressing. They have to. It is a life or death situation. And nothing motivates us more than horrible things like that. And so it will be hard, but this is something that's very interesting for yourselves, but also for if you're carers, if you're interested in the research of this, if you're interested in supporting the science of this, etc. This is the future. So the agenda is, what is OMICO? What is this company? What do they do? What do we test? What is genomics? What is this? Obviously, we're here today to talk about bladder cancer. Bladder cancer is ripe an area for genomics. There are so many targeted therapeutic drug options that are based on genomics. It's a very up and coming, important, patient-centered problem to focus on. And then we'll deal with self-advocacy. What do you need to know for yourself, and how might you broach this with relevant parties? So just a quick thank you. Thank you to Beat. Thank you to our lovely OMICO team and all of our staff, and also, of course, our long-suffering bladder patients with all of the horrible symptoms that come with this disease. They have contributed to a lot of the knowledge that I'm going to share with you now today. This is just a little motivation, but if it doesn't challenge you, it won't change you. So yeah, anyway, let's buckle up. So what is OMICO? There are children equivalents. So when a child has cancer, they get an analysis of their cancer with genomic data. So that specific cancer is taken, analyzed, DNA is taken out of it, RNA is taken out of that sample, and then we sequence that RNA and DNA structure and see what's different about it, what could be targeted. There is a hematology, a blood cancer equivalent, and then there's an adult cancer program, and OMICO is the adult cancer. So all adult cancer, anyone with any solid cancer that is metastatic, stage 4, has already spread somewhere else, stage 4. It gets this analysis done once in their lifetime for free. And we have done, this will give you an idea of how quickly we're doing this. We've now done 18,000 cases sequenced so far. So it was 17,000 when I wrote these slides just a few weeks ago. Our future vision includes focusing on rare and disadvantaged subtypes, including bladder cancer, creation of all-comer trials. So one of the issues is often you make a trial too specific, and then there's only 2 or 3 patients can get on that trial, versus trying to make more trials that can allow lots of patients to come on board. And then expanding something called IHC, which is not quite genomics. It's another target that you find on the on the membrane of the cancer cell, on the very edge of the cancer cell that you could target to. So that there's some of the things that we're working on. Why should you bother listening to this? Well, in current clinic, there are no panels, no genomic panels at all in bladder cancer. So there is no government-funded test equivalent to this, albeit OMICO is a not-for-profit organization that is predominantly funded by the government. It is, in my opinion, I think I'm obviously a little bit biased, but I don't think I'm too biased. It is the best comprehensive genomic panel that we have available in Australia, even if you were to pay thousands of dollars. We have been very pleased to see that this company allowing free tests to everyone has markedly reduced the difference between rural patient cancer outcomes and urban outcomes. So we're getting a lot more smaller hospitals engaged. There are a lot more trials coming to country, and then there were beforehand a lot more. It's very noticeable, the difference since we've established ourselves. That also extends out to different subgroups. So we have a lot more ethnicity groups represented than has historically been the case in the past. A lot more Indigenous Australians being represented. And all of this interest, all of this drive and motivation is changing cancer patients' knowledge, and they're treating physicians and treating nurses' knowledge. So we are definitely becoming smarter as a country as a result of this. In my hospital, what's different, if you came to me and said, well, I've got bladder cancer, what my hospital can do is it can tell you, all right, yes, you have bladder cancer. I can see that from the microscope. And it will be able to tell me most of the time what subtype of bladder cancer you have. It will not be able to tell me anything else. I will not be able to tell if you have any genes or signatures that I can target. It will not tell me, are there any kind of trials that you could qualify for? It will not tell me if you're strange from the normal standard, if you're very different from that normal standard. I won't have any idea. And so what does CASP do? Well, it screens to see if you've inherited cancer. It screens 500 odd DNA genes to look at that would not be looked at otherwise, 55 RNA genes, lots of other fancy stuff. If you're a borderline or a strange case, we review that. If you are a cancer where we don't know where the subtype has come from, or we don't know what type of cancer even you have, that will get reviewed as well. So there's lots of that not black and white problem that happens often in medicine can be sorted out by these tests too. And then you get a personalized report and a personalized trials option prescription for each case. What do we need? Well, normally I need a tissue. We don't like blood. By a lot of people, a lot of patients, a lot of physicians think that there's all this amazing amount of data we can get from blood. People think you go to your GP and you get a blood test, and lots of magic happens, and they're able to tell you what you had for breakfast 3 days ago, and how they're going to do their toast. It doesn't work that way. Most of the time, there isn't as much reliability from blood as there is from a tissue biopsy in solid tumor cancer. Obviously, that's different if you've got blood cancer like leukemia. That's different, right? But bladder is not a blood cancer. It's a solid tumor cancer. It needs to be representative, so you can't be giving a biopsy from 10 years ago and think that that's going to be up to date enough. It doesn't check for all genes, but there's a big list of them there on the right. And why does it take so long? The average time is about 6 to 8 weeks. You sign up to this program, and it takes 6 to 8 weeks for the results to come back. There's just a lot of curation. There's a lot of work that goes in behind the scene. But to be honest, the main delays are patients worried or taking their time and not quite realizing that that the buck stops with them. If they don't consent and get on the program, it could take, I've some patients sitting on this for 3 or 4 weeks, and then 12 weeks later they go, why did that take so long? And I have to hold my tongue and go, well, you sat on it for a month. The other issue is getting those samples from other laboratories into our lab too. So we're working on the turnaround times, but they do take a bit of time, 6 to 8 weeks. So these are just the start of some of my analogies. So needing to be representative, and I want to give you the example of this gene called FGFR3, which is a very targetable gene. So if you look at the bladder on the right here, this is a cross section of the bladder. Bladder cancer comes in multiple different stages, and I'm sure you will have had lectures on this before. There's a big difference between a bladder cancer that's just fronding like a little fern on the left column here. It's just fronding out into the bladder space, versus that great big aggressive, the great big aggressive ones on the right there, where they're just penetrating through the whole of the muscle. They're very different types of tumors, and their genes look very different as well. So if you gave me a sample that was of your old cancer 10 years ago, when it was a fern-like cancer, like on the left, I may not have the knowledge that I need to actually help you get onto a trial. And I want you to think of it as that these two pictures here on the bottom left. If you give me a very clear picture of you right now, I'll be able to tell what's going on. Whereas if you look at that old rusty picture on the far left, I can't really tell. I can maybe tell what's going on, but it makes it much more difficult for me to see. So an old biopsy is like a very unclear picture. If the more recent biopsy you give me, the more I can tell you what this tumor is about. What might we be able to do with it? What can't we do? What we don't. For that reason, if you have bladder cancer that is in the curative stage, and I hope it remains curative for you forever, then we don't do those biopsies. There's a couple of reasons for that. One, I'm hopeful that you will be cured, and that cure could be permanent, or it could be for many, many years from now. And so we don't do a biopsy on something that we don't need to do, and we also don't sequence something that's too old. So if the cancer comes back, hopefully it never does, but if it comes back in 5 years or 7 years, we have that old picture problem. Just like M&M, you only get one shot as well. So there's just one time you're allowed to do this on the program. We have to give this to all Australians, and there is a budget constraint. So there's one person is allowed to do one biopsy per time. That said, if you have 3 different cancers, I think 3 different types of cancers, I don't think that rule remains. Sometimes the samples don't tell us very much, so that's a caveat. That's a problem. And then if you're at a time when you're lucky enough, you don't have much tissue at all, you have very low burden disease, there's very little cancer in you, or maybe no cancer in you, the CT looks great, your oncologist says, well, obviously that's not the right time either. We want something, we want a sample where the cancer is active and we're actually going to get an accurate picture of what's going on. People are often worried about trials, and this is our big focus in OMICO. we want to get patients onto trials. We want to get them matched to therapies, because if they're matched to targeted therapies, they do better. And people are worried about trials. And I think some of my patients think if you think of trials like traveling, going on a journey, some of my patients think this left picture is what's going to happen when they go traveling. You know, they're going to go to some civil war zone. There's going to be people flinging bazookas all over the place. It's going to be Thailand and Cambodia border zone. Whereas actually, most of the trials, I think of trials as someone going to Bali. They pretty much, I pretty much know what's going to happen, more or less. Most of the time, it's pretty safe. You know what you're going to get. Yes, of course, you could get Bali belly. There's a few things that could go wrong, but it's not quite as scary or experimental as maybe it used to be back in the day. A lot of these trials are using drugs I already kind of half know, or have already been somewhat trialed before. Or even when they say that they're a new drug, a lot of the time they're not really a new drug. They're kind of a slightly different context, or a different brand, a different company. But we kind of half know the drugs. So I want you to think of trials going to Bali more than going to the civil war zone. There is a little bit of a caveat on that. If you think, if we're continuing on this analogy of travel, if you think of yourself, when we start off with a really good passport, and we can travel everywhere. We can go wherever we want. We can do whatever we want. We can kind of say to people, well, I'm not going to do that treatment. I'm going to do this one. Or I want to preference staying at home for longer, so I'm not going to go and do that trial. There's usually several options. And in particular in bladder cancer, there are several options, which is great. As we go through our options, we become a little bit more desperate together. Certainly I do as the clinician. And so we kind of lose our passport rights. We have not as good a passport anymore. We can only really go to a couple of countries, and we kind of have to make a few compromises as a result with that. And it depends on where you are in your journey, but later on, you often have to look at trials that aren't bladder specific. They're more all comers, or they're more some agent, some drug that could be used by lots of people, lots of different cancer types. I'll move on from this, but it's really just to say most of bladder is one type, something called TCC, but it can be lots of other types of bladder cancer, and we do look at that in our group. These are the types of genes that is typically found in bladder cancer, in that TCC type, that really common type, 90%. And if you just have a little look here in the bottom right, I want you just to see all of these lovely patients who have contributed to the 275 samples we've sequenced so far. So they're from all across Australia. There's I've just put it in, there are places in WA as well, but just for space reasons. Looking at those gene profiles, one gene sticks out, called ERBB2 or HER2. Some of you in the audience may have heard of this before. This is a target that has a lot of options attached to it in trials. So it's something that's very, very useful to find out whether it's present or not. The next down is PIK3CA. And well, 20%, 21%. It depends on how I cut them. Sometimes it's like one of them's higher than the other, but they're about a fifth in each case. Next one is called MTAP loss, and then the next one is called FGFR3. You don't have to know what they are, but I do want you to know that genes exist that could be targeted, and there are some genes that are much more important to rule out than others. And these are the real heavy hitting ones. You as the bladder group these are your genes. These are the genes that you're interested in. People that have breast cancer won't be interested in some of those genes. But if you have bladder cancer, they're the genes that come up commonly. And you can see here that fairly similar average age and male predominance. These are things that we know from beforehand. There are a couple of concepts that I want to.
Before you move on, Greg, should we
How are we
address
doing
one
for
or two?
time?
Are we fine for time? Just one or two
Okay.
questions. Going back to the last slide, is there a difference between males and females in the data that you found thus far?
I'm presuming by that, and just correct us if that's not what you meant. But no, there are no genetic differences between male and female in terms of targetability.
Oh.
If that's what was meant, no, there isn't.
Okay, I think that's what was meant. Another question was, someone mentioned trials have always been considered the last port of call when it comes to treatment option then in sort of advanced cancer, which is slightly different, I think, to what you mentioned. Did you want to speak to that?
Yeah. So, Helen, I'm glad you're bringing it up, because I'll challenge it back to I want you to think of trials more as you're going to Bali, not to a civil war zone. So, it should be part of standard of care. We are lucky. I say that in kind of inverted commas because we're not really that lucky, but we at least have a few options in bladder cancer. There are certain cancer types where we have one option and then that's it. So there are a few options, but it is definitely not perfect. And if we're waiting till the very end, I think sometimes people don't end up going on a trial. If we're thinking about trials as overly scary, we end up never changing things or making things for the better. And I think there's a very strong feeling a lot of people have about this kind of last ditch effort, and that it's really dangerous and all the rest. It just isn't that dangerous on trials. There are a few things that the trialist works out on your behalf, but it's really just as safe as standard of care, to be honest. There isn't a difference. It's an important thing. I come across this with my patients all of the time, that they have a very strong view against trials, and I guess it's changed. In my opinion, it's changed. And where I think the big difference is that a lot of these trials, they're not bladder specific. They are mutation specific. So these mutations that are up on the screen here, there is a HER2 specific trial for your HER2 specific mutation. There is a PIK3CA trial for your PIK3CA specific mutation. And so you're not specifying it to your cancer type, you're specifying it to your mutation. And that's not always the correct way to conceive of it. You may have some really good options that your oncologist says, look, that's way better, don't do that, or this, I've had a look at the protocol of that trial and it looks like a real pain in the bum, right? So don't do that, or certainly don't do it now, maybe think about it later. It doesn't mean you all have to jump onto the trial bandwagon, but the reason why I bring it up is just there are so few people going on to trials, and I know that it's because of this perception that it's overly dangerous or overly experimental. I know this because it's the thing that I keep coming across from my own patients.
Great.
Now,
that's great. One more question before we move on. Just this graph, while we've got the graph up, is there a relation between the pink bar graph with the types of genes versus the sort of plots chart on the map at the bottom with the orange dots?
No.
Okay.
There isn't. There's not.
Great.
So I'll go on to this concept. So, sorry about all of these words. You don't have to know the words so much, but just the concepts. MSIH, this is not a very common thing in bladder cancer. It's very uncommon. But something that is very common is TMB, tumor mutational burden. It is very common in bladder cancer. You didn't see it in the graph here in this bar plot, but it's separate to that. It's at least 20–30% of all cases. It's probably actually an underestimate. It's a little bit higher than that. So if you see high TMB, high tumor mutational burden, that is a marker that that cancer could respond to immunotherapy even better than usual. And immunotherapy is something that's very commonly used in bladder cancer and has shown efficacy regardless. But in a subset of bladder cancer, it may be even more effective than usual. And so back to our analogies, I want you to think of a cancer that has high tumor mutational burden, like this mutant toad here on the top right. So he's a great big warty mutant toad. He's got loads of mutations all over his skin and he looks crazy. So this is what the cancer cell looks like. It's got all of these mutations everywhere, and it looks absolutely foreign and weird, and it looks like it shouldn't be there. But the issue is that in cancer, a lot of the time, the immune system is asleep at the wheel. And so we've got this kind of lazy single security guard down here. He's got his mask up. He's got his cap down. He can barely see anything, and he's sleeping. So even though you got this great big obvious warty toad flying around the place, this guy's never going to find him. And cancer is also alive, and it has tricks as well. So cancer's like that little guy in the top, on the bottom right, bottom left here. He's like this sneaky little guy, up to no good, sneaking past this security guard, even though he looks as obvious as this big warty toad. And so what immune therapy does is they change out that lazy guard, they fire him or they put him somewhere else where he can't do any more damage. And there's a whole crack troop come on board instead. So that it really gives muscle to your immune system to find that warty toad for you. And in tumor mutational burden high bladder cancer types, that's even more likely to be effective, because the more mutations, the more warty and foreign and weird the cancer looks. These are some other examples of other immunotherapy trials, because we have some immunotherapy trials that are normal in bladder cancer that we use all the time: pembrolizumab or nivolumab or avelumab. These are agents that you may have heard of before that are used as just standard of care now. These are the new up-and-coming ones, and these are currently recruiting at the moment. So you have the first example here, this top one. When you get a cold, you get a fever. And it's that fever, that fever is not actually the infection, it's your own body's immune system. And you get that fever via something called IL-2. It's a molecule that your body releases. This drug basically does that. It's a sister of that molecule. It makes you, and you also do get a bit of a temperature from, it's quite tolerable. And it is showing success. So this Medicina trial. The next one down the line, sometimes immunotherapy doesn't work. One of the reasons for that is that if you think of it as there's too many bureaucrats regulating everything, there's too much red tape stopping this little fellow in the middle picture here, stopping him being able to do his work. And so tiragolumab, this drug, adds on to normal immunotherapy, and it just cuts out that red tape so that the immune therapy has a bit less bureaucracy that it has to get through to actually get the job done. This one here, in patients with MSI high disease, this subtype of bladder cancer, it's only in about 2%, they seem to unwind their DNA, which is like spaghetti, differently. So DNA scrunches up like spaghetti, but their DNA scrunches up differently. And it scrunches up differently using a different fork, and it keeps getting tangled. And there's this drug, and let's call him Werner. It's Werner helicase inhibitor. So Werner comes around and helps the cancer cells unwind their spaghetti. What we do is we kick Werner off that cancer cell and give him an all expenses paid trip to Hawaii for the year. So he isn't coming back anytime soon. And so then you get this great big globby mess of DNA. It can't unwind, and then the cancer dies. That's the idea. I'll go on to HER2 as a target. This is one of the big top ones. So I want you to, there are two ways to target HER2. And it's a little bit of a cat and mouse type of thing. So the cancer's alive, and it keeps coming up with tricks to get over our tricks, right? So it's not a static thing. So we have antibodies, and they are like this knight here in the middle photo. So this knight, well, he's not a knight, actually, sorry, he's an evil. This is the cancer in the middle, right? All the knights are at the side. So the cancer's inside, and he's trying to get out, but he's been blocked by shields. So that's what the antibodies against HER2 are. They're like shields. They block it being able to do any badness. Whereas there's a new kid off the block, and they're called ADCs, antibody drug conjugates. And they're a little bit like, imagine in the top right here, this fellow, he's just robbed someone, and he's taken the person. He thinks he's doing a great job. He's the cancer cell, but he's been watched the whole time for bad behavior, and these guys have just been waiting in the background to get him. So that's what an ADC drug is. It's observing for bad behavior. You're going to a place that you shouldn't be going to. Okay, then I'm going to release a crack team into your cancer cell and kill it with chemotherapy payload, but it doesn't hurt you too much. FGFR3 is another very big target in bladder cancer. This one you conceive of as a lock and key, and there's a range of complexity to these lock and key type gene problems. The key to the lock is something called TKI, tyrosine kinase inhibitor. And sometimes it can be really easy. You just have a little plain old lock there like we have in the middle. It's nice and easy. You just stick the small little key in and it fits, and the lock unlocks, and the cancer cell then dies. Sometimes the cancer is pretty sophisticated, and you've got a lock like you have down here in the bottom right, and really, really sophisticated, lots of different mutations and resistance patterns. And the older the cancer is and wiser it is, the more it turns into a lock and key system like that. You're constantly thinking on the top right here, the cancer cell is always coming up with new powers to attack the normal body, which is represented by the lady in the wings on the left. PIK3CA is another big one in bladder cancer. It is another lock and key concept, but there's another aspect to this too that's a new development. The lock and key we found caused a lot of side effects, probably a little bit too much. I'm not sure whether I would have gone on some of the older trials. We have developed mutation specific, so not just PIK3CA. We have developed drugs that will do a subtype of PIK3CA and target it. And basically it's because we're so specific, it's more effective, but there's also a lot less toxicity. And if you think of that as you know, the older drugs, it was a little bit like this guy. Can you go out and blow up the house with this bazooka? And so he did, but he's also blowing up the garden and half of the rest. So that's someone's body. Versus on the right here, you now have a much more sophisticated model where it's just a little shoe over the cockroach. Now, whether or not that cockroach will die, I don't know. But there are these other genes as well, HRR genes, and there's a list of them there. These HRR genes, I want you to think that, so the cancer came about because the genes have given the cancer the ability to get a bit confused. The cell gets a bit confused, so it keeps making mutations, and it keeps making little kind of powers for the cancer can use. But that ability is now turned on its head by these drugs, that ramp up that problem. So think of this, the accountant on the left here, he's just about holding it together. There's loads of stuff he has to read. He has to read loads of DNA, loads of things, make sure he gets all of them accurate. Every pound for pound is accurately recorded. And then what we've done is we've given him a drug, a PARP inhibitor drug. And if you think of that siren going PARP, PARP, PARP in the background, all of a sudden he just loses his mind. He can't do any of the sums anymore. There's too many readings and proofreadings to do. So the cancer cell then dies. And that's basically how the PARP inhibitors work. And there are lots of different drugs in this field that are pretty exciting coming up. They're not bladder specific, but bladder cancer patients can certainly go on them. Then another one, I think we're close to the end of this section, MTAP loss. Similar kind of concept to the accountant. This is a mafia boss, and he's having a great old time. His business is getting bigger. He's stealing this and stealing that. What these MTAP inhibitor drugs do is they go in the back door and work out a way to turn his waste, to turn all of his little paperwork against him. So the cancer cell has left some paperwork in the back cupboard, and we use that paperwork against the cancer cell, so that he then is put in jail, right? The cancer cell dies. So that's how MTAP inhibitors work. There are loads of trials in this at the minute, and it's about 70% of bladder cancer that has that. So just moving on to the last one or two slides. I'm not sure whether I've confused you guys way too much. I hope that maybe you got some of the analogies. Who should go on to this program? Who should submit themselves to this, to getting these genes looked at? Well, anyone that has limited options, anyone that has a rare cancer. If you've got a very rare bladder cancer, then you really should be going on to this program. If there's something strange about your case, if you are very interested in trials, when we talked about we don't do it whenever you're in the curative setting. We do it when you're in stage 4. We usually will say, from a bladder cancer perspective, maybe you might think about it after the first line of treatment or during the first line of your therapy onwards. But if you've a very rare bladder cancer, you should probably do it the earlier the better. And then, this is just to remind you, what do the genes look like? What genes do you need to know as a bladder cancer patient that need to have been checked for? They're the important ones. How do you have a conversation with your oncologist? Well, first of all, because it has to be an oncologist that orders this, it can't be a patient, it can't be a GP. First of all, start the conversation, but probably not the very first time you meet your oncologist. You have too much to talk about then. You could ask for an extra appointment or to make that the specific thing that you'd be talking about in that appointment. You could demonstrate interest or trial willingness. If you've a very old biopsy, you now know, okay, well, if it's too old, maybe I should do a fresh biopsy. And you could have a conversation with about that. But basically, it's enthusiasm is the key here. If you do have a very sluggish clinician, you can take some of that burden off them by being enthusiastic. You could use your nursing staff as allies within that to get the job done. And this kind of second opinion privately, I think that's, you're in dodgier territory there. You only really think about something like that if you really have a clinician that, has kind of repeatedly demonstrated to you that they're just not interested. I think that happens a lot less than we say it does. And then these are just more what's coming. Maybe things that I will say on this that I want you to know about because we care. There are so many more trials. We have increased a lot of trials coming to Australia, and there are a lot more companies interested now. And the more patients that sign up to the program, and the more interest is generated, more companies. It's this self-fulfilling prophecy. We also have performed the world's first teletrials in quite a few different models. That's quite amazing. So that's a big boon for our country patients, but just in general. And we look forward to integrating Queensland in particular more into our model. So we're working on that. And I'll just flick back to the genes, because that's the one I really want you guys to have a think about. And that is the end of the talk. So we could talk about some questions. I'm sure there might be, I think there are a few.
Well, I've kind of thrown them at you. It's more comments. Questions, everyone? Do you want to post some in the chat? I forgot to remind you. We quite like that last slide that you have with some of the questions to take with to the oncology appointment. So we might just steal that and put it in our patient question list. Yeah, I just want to, well, thank you firstly for a very interesting talk, and these concepts are really complex. Like someone else commented there, do the urologists know this? And I said, no, probably not. I think our patients now probably know more than the average urologist about this, because it's not something we learn about. It's not our scope. We just operate and remove things. We don't really learn about all these complex genes and what's happening inside the cells at this level of detail anyway. So yeah, it's just fascinating. And this is just the beginning, isn't it? I know you're saying it's not for curative stuff, it's more for the advanced stages for now, but it's only a matter of time before you move into the curative space, I'm quite sure. And I'm sure many urologists probably don't have an interest in this because this may replace surgery one day. Maybe there will be no need to have an operation. This may become the curative option. What do you say to that, Greg?
The companies will always want to bring drugs into earlier settings. We obviously have to be careful that we're not over interpreting data that we see in stage 4 to earlier stages. But I think something like FGFR3 or ERBB2, they're extremely likely to be positive in the curative setting as well, extremely likely. And I could see a model like before your surgery, you get analysis of your genome and you find an ERBB2 mutation. And so you work out with your oncologist, okay, well, we're going to have chemo, but we're also going to add in this targeted agent. And you have that for a couple of cycles. Then you have the surgery and there's a better outcome, right? But you'd have to prove that. It isn't always the case that happens. So you wouldn't want to just jump off the ledge and make that assumption. But yeah, I can absolutely see that coming in bladder cancer.
Yeah, it's only a matter of time, isn't it?
Mm.
I mean, we've already seen an explosion of immunotherapy options and antibody drug conjugates, and we've created an algorithm for advanced cancer, but I think we're going to be updating that fairly regularly with all the new options available. Um, the other thing I wanted to ask you, I see there is a question that's come in, and post questions, everyone, before our speaker leaves. You can go for like a DNA testing, to test for like what drugs you will respond to, like some of the psychiatric meds or whatever. Does that testing include this testing for these immunotherapy drugs, or is this very specialized kind of testing?
So that test, that pharmacogenomic test, is about $160, and it's done in the back of someone's shed. This test costs about 10 grand if you
Wow.
wanted to get it privately. So yeah, there's a big difference. Those tests as well to look for sensitivities to drugs. Most of them, the vast bulk of them, are actually based on very minimal science at all, and so it's quite easy for them to make these companies, quite easy for them to make these tests and have these assumptions, but actually you have to go back to the science and work out whether or not some of these tests are really real at all. So yeah, you can't get a test like this very easily without paying at least. I mean, the cheapest you could probably get it maybe 550, 600, something like that.
Mm.
Obviously, it's more useful to do it to get it for free. But if someone were very, very interested in a context where you didn't qualify for the program yet, you could pay for the test. I'm sure you could pay for a test. St. Vincent's, Monash, LifeStrands, lots of different companies do this. I'm very biased, but personally, the more knowledge, the better. Why not? The issue is going to be, I think, someone in the group asked, when do
When will it be
Vera,
available?
when do you think it's going to be available in earlier stages? We're not even mildly there. I think that's going to be, 3-4 years until we really properly start experimenting with this. I'm always a little bit surprised by how rich the genomics are in bladder, but how little traction we're only kind of making baby steps so far in bladder cancer, even though it's one of the strongest targetable cancer types out there. It's way more targetable than prostate, for example, would be.
Mm.
You know, there are a lot. You saw that there. There's 20% this, 20% likelihood of this, 20% likelihood of that, 17 this, 17 that, 30% this. These are not small numbers. If you add all those up, it's a pretty big portion of the community will have at least one targetable gene that we can manipulate. Some of them are not as good as others. I think ERBB2 and FGFR3 are big ones. Some of them are quite rare, but really good that I didn't talk about. So yeah, but if you don't look, you don't get. That's the thing. Are these tests affecting your bone marrow? No, I'm not sure. I'm not sure exactly what that's getting at, but no, they don't affect
I'm
your
not,
bone marrow.
also not sure. I had a question for, there's one other one on SCC. Um, a comment. Well, show my age here, but I learned about this stuff about 20 years ago when we did molecular medicine, just the concepts, right? And we're
Mm.
only seeing the treatments happening now. That's how slowly this stuff sort of moves or starts coming to the mainstream. So it just doesn't happen fast. And is that because there's so few of you that can do this kind of work? Or is it because of how much it actually costs to develop the technology? Is there just not enough funding that goes into this research? Like, what's the reason it moves so slow?
It's a very difficult question to ask in a short space to answer in a short space of time. But so there is a big discrepancy between tumor types. Breast cancer is definitely advancing quicker than other types. because there is more money and interest, and there are more people in general. Bladder cancer is not as common. It is in a frailer population as well, and it is in a population that has stereotypically or historically been more resistant towards trials than in breast cancer, where patients are much more open to trials, much more open to that being as a standard of care. They also obviously have more options, so it's kind of a chicken and egg scenario. They are difficult concepts. We've only recently, in the past couple of years, had proper, reliable molecular tests that are somewhat cheap. So that's been a big block as well. And yeah, I mean, it does require people to be interested in general. So there's only so many people that are interested in bladder cancer, and there needs to be more people. There needs to be more patients, more funding, more research, more science interested in it.
More celebrities and high-profile people getting this type of cancer. That's usually happens. But it's
the
funny.
Angelina Jolie effect.
Yeah, that's right. And isn't it amazing what we saw in the pandemic? How things can get done when there's suddenly a need for it and there's money thrown at it. So, okay, there's a few more questions coming. Someone's talking about squamous cell carcinoma.
Yeah, would SCC bladder cancer qualify for testing from 6-month-old cystectomy? It might actually. So there's a couple of rules there. You can only get it once. So if you didn't, if you had a very low risk SCC bladder cancer, it is probably not a good time to do the test. But if you spoke with your oncologist and it was a high risk SCC bladder cancer, so you've had it removed, but there's quite a high risk of it coming back according to your oncologist, then because it is rare, it's not the standard TCC bladder cancer, a rare bladder cancer, we do tend to offer that sequencing from now. So yeah, that would qualify. Speaker said, "This is the future. Are there valid competing views from serious professionals?" As opposed to some other future being the future. There are other avenues. This is the current future. It doesn't mean that it's the permanent future. There are other scientific avenues that we will discover over time. I'm very hopeful of that. But this is the future for the next couple of years. This is where all of the interest, all of the money, all of the science has been placed on these types of approaches.
Right, and you can see the next question was younger people are getting bladder cancer. I think it's just a comment. Someone else.
Yeah, well, more young people in general are getting more cancers in general. It's a horrible trend, and Australia is unfortunately one of the leaders in that, and we don't really know why. We don't understand why. So we have a really high proportion of younger onset pan cancers, all types of cancers happening over the last 5-10 years, and it's awful. We don't really know why.
Someone else commenting on breast cancer, no genetic markers on mine or father's side. She had, this is a second cancer, not a secondary, but she had breast cancer previously and then developed bladder cancer later on the line. But is there a link? You think there could be a HER2 association?
No, so if it's from breast cancer chemotherapy, I'm not too sure. I'm not too sure how to follow that per se. There are two types of genetics, just maybe, that she's kind of talking about there. There is cancer genetics that happen to the cancer itself, and that's because the cancer starts to develop powers, and it uses mutations as a way to develop powers against you. The second type of genetics is genetics that you inherit from your mom and dad. So they're separate. The test is mainly developed for the cancer genetics, not the hereditary genetics that you get from mom and dad. But sometimes we will also find that too in as part of the assay.
And then there's one last question. I've just received notification. My testing report is with my oncologist from your team. My scans have been clear since last year. A radical cystectomy with my oncologist have requested this because I have small cell carcinoma.
Small cell is unfortunately one of the unusual subtypes. It's not a common type. And so we all feel, including oncologists, that if it's rare, we need to look at it because, I gave you data there on these genes. It's unclear to me whether that holds true in a small cell subtype of bladder cancer. And everyone needs to know that, including you, that you need to know what type of genes I should be targeting, I should be thinking about. But also it provides options, targetable options for that person, for that individual person with small cell cancer right there, right now. It's not just for research. It's to actually affect change in that specific patient that has a rare cancer.
Thanks. And another person said they had chemotherapy for their lymphoma when they were younger, cyclophosphamide, and that their bladder cancer is linked, they think, might be related to that. It is a risk factor.
It's a risk factor. It's usually not the only play, right? So there's usually a couple of different stories in anything. And I think if the point of writing that is to say that I don't need to check because I already know the cause, it doesn't mean that there may not be some other gene that's changed in that cancer that could be manipulated and could be targeted. So there may still be a point in doing the test, I guess, even if you know for certain it was caused by this chemical or that chemical in your 20s, it doesn't negate the possibility that you could have something that was targetable that you could go on a trial for.
Yeah. And we had a question, out of these 275 people on the slide, how many went on to treatment? Do you have that kind of data? Is it available or available for sharing?
So that's a complicated question because there's a delay. So when I sequence someone, they get the result 8 weeks later, and then they're already on a therapy, and they're not going to jump off that therapy to go on straight onto a trial, right? That wouldn't make sense. So if they're responding to the treatment, they keep going on to the treatment until they then eventually that treatment doesn't work, or it does work and they just keep on that treatment. After that, then they have to be willing to go on to a trial and not have any other better options that are available as standard of care, which in bladder cancer is usually maybe second line or third line by which stage. So how long does all that take? That might take maybe a year and a half. So we're only now starting to see an uptake. We started this program about kind of 2-3 years ago. We're only now starting to see this kind of exponential trend of people going on to trials because there's a delay. But people don't need, when they do this test, they don't usually need the answer immediately. They need it in, could be 6 months, could be a year from now. The other caveat to that too is not everyone goes on a trial, but they might pay for a drug, or they might do something else. They may buy that drug that's available in the market and use it. And that's not that uncommon as well.
Well, thank you, Greg.